The brief history of this patient, he was a DCMP patient due to acute myocarditis, diagnosed in 2011. And 8 years later, repeated cardiac arrest due to ventricular fibrillation. He put the transvenous ICD to the right ventricular apex. And 2023, multiple ICD shock had occurred and also cerebral infarct. And he tried to have a CRT, tried but failed. And then conduction system pacing, LBB area pacing is applied. But the result of the CSP was not very good, and the QRS duration was not very much improved. So multiple recurrent VT occurred again, and then LVAD and heart presentation in this year. So we have a heart specimen with conduction system pacing with us, and I'll show what is in the heart and show you how we can improve our conduction system pacing. Next slide, please. First of all, I'd like to show the fixed PowerPoint picture. On the left side, it is anterior aspect, so we can see right ventricle, left ventricle, and heart rate 3 at the apex. And on the right side, in the same position, we are making the right ventricular opening to show right ventricular septal surface. I'll show in the same sequence of this slide, and then just remember this sequence. Next slide, please. And then we are looking at the mitral valve on the left side and right tricuspid valve on the right side. On the right panel, we are looking close up the tricuspid valve from the apex, right atrium. We can see conduction system pacing lead and also right ventricular apex ICD lead in the same place. Next slide, please. And then we are looking at the septal surface of right ventricle to show CSP lead close-up. And then on the right panel, we are looking at the other side of the chamber, left ventricle, where CSP lead is going to approach. Next slide, please. And then we cut the plane where the CSP lead is, and then we are looking at details of how CSP lead is approaching the septum and so on. Next slide, please. And this is the scar seen from the left ventricle. Next slide, please. Now, next slide, please. Now I made the histology section of the same patient and the same location to show the upper part is left ventricular endocardium and lower part is right ventricular endocardium. We can clearly see on the upper part that endocardium is thickened, and bluish area covers transmural fibrosis in this area. The midline defect of the tissue is where the CSP lead is placed. Next slide, please. And if I close up, we can see on the left side is this patient, and the right side is normal histology of that similar area. So on the left side, we can see, in addition to thickening of fibrosis of endocardium, but also we are looking smooth muscle, subendocardial smooth muscle, not cardiac muscle, crumbled on the surface. And then just below that, there is a thin layer of left bundle branch area. Maybe you can recognize. And the right side, we are looking at the much bigger left bundle, which is just subendocardial location, and so on. And the deeper part is myocardium. So the difference from the left and right is that on the right side, the endocardium is thin, and on the left side, the endocardium is thick, and smooth muscle is hypertrophied. The reason we have this kind of smooth muscle thickening is that the heart was enlarged at the original position, but due to heart rate 3, the size of the heart is shrunken so that endocardial fibrous smooth muscle layer become crumbled to make that kind of artifact, or just it is also still pathology. And also we can recognize that there is an extensive fibrosis transmurally, and it is very hard to approach the left bundle branch tissue, and it's very atrophic on the left side compared to the right side, where the thick subendocardial left bundle tissue is there. Next slide, please. Okay, let's move to specimen view. Specimen, please. No. Yeah, specimen. Okay. This is the heart we have shown by PowerPoint slide. So we are looking at LVAD from the left ventricular apex. This is left ventricle. There is an anterior descending coronary artery. This part is right ventricle. This is conduit from LVAD to ascending aorta, which looks very tortuous. That's because at the original heart was very big, and heart mate was placed like this, and then by becoming smaller the heart, the conduit become very tortuous. But it is natural. It is common in the heart after LVAD placement. And we are looking at the right ventricular septal surface. Yes. Right ventricular septal surface, that this is anterior papillary muscle, this is pulmonary valve, and this is septal surface leaflet, and anterior tricuspid leaflet, septal leaflet, and so on. So, and also we saw in this view to see mitral valve and tricuspid valve. On tricuspid valve, we have two electronic leads. One is perpendicular to the right ventricular septum, which is conduction system pacing lead, and the longitudinal lead to right ventricular apex is IC lead for placed right ventricle. And also there is a lead is here that is embedded in this right atrial wall, and it is common after placing this lead, the endocardial growth covered, and it is right ventricle going to right ventricle. So by time passing, the catheter lead is embedded and fixed to the atrial wall. So now we will see details of the CSP lead from like this. So I have shown from the PowerPoint slide that CSP lead was placed somewhere. This is ICD lead to the right ventricular apex. Okay, thank you for that. So what do you think about this CSP lead placement? This part is membranous septum, atrioventricular membranous septum. This part is interventricular membranous septum. So I found this location of CSP lead is perfect. Perfect. That means the CS from the right side, the fold is in this way, but from the left side, it fold going to this way. So if conduction his bundle is there, the inferiorly, this part is very good position for CSP lead. And then we are looking at the cut surface to see how much it penetrated the CSP lead to the septum, and also we are looking at how much we can go approach to subendocardium of left ventricle. This is mitral valve, and this is left ventricle. So the thickness is not easy for you to recognize the thickness, but it's about 8 millimeters thick, the whole septum. So the septal thickness depending on where you approach. So to the base it is thin, and to the apex it is thick. So at this 8 millimeter thickness is it means, I think, it's a good positioning of the CSP lead. But I could see the CSP lead penetrated only 1/3 of this septum. So it was the Dr. Park Jae-seok said in this particular patient, the ICD lead was already used left subclavian vein. And then the second CRT lead was tried but failed. And then the third, the CSP lead could try to place subclavian vein, but it was very hard to approach due to fibrosis at that area. So he said it was not complete for his design. So rotation torque was not enough. So he worried about the insufficient penetration of the catheter, the electronic lead. So we can see this is full thickness, and this is only penetrated. So subendocardial left bundle is here, but it is too shallow to penetrate. And also, we have seen the histology of this area, that the diffuse fibrosis of this area could make atrophy of left bundle branch in area. So in this particular case, Dr. Park and me discussed about the condition of left bundle branch tissue in this particular patient. That means we will look at from the left ventricle. From the left ventricle, this is mitral anteriorly flat, non-coronary cusp. This is membranous septum. This is where his bundle approaches to left bundle, and it goes down to here. So his bundle pacing would be about this area, and his bundle, left bundle branch area pacing would be around this, and then in between them, this patient have pacing tried in this position, which is the exact location of the major part of his left bundle is going. But it was superficial, and this part is fibrotic, and the left bundle branch and at this level was atrophy. So we discussed, but we'd better try LBB area pacing more to the apical side, because it would be safer. And if possible, we could do some mapping of viable left bundle branch LBB tissue from the left side, and to determine how far from the beginning of the LBB to the placement of LBB area pacing. So this case was conduction system pacing was tried, but not sufficient. The reason was, one is the massive fibrosis of this area due to myocarditis, and the second is the too shallow approach of the CSP lead in this patient. So we don't know if the patient have more penetration of the CSP lead, but because of the fibrosis, it was it has to be very hard to produce good QRS complex by the CSP lead. And also in this patient, he said he tried to CRT lead placement but failed. But I'll show how CRT lead is going to applied. So from the right atrium, we are looking at a tricuspid valve, and this is orifice of the coronary sinus, which goes to this way. So coronary sinus is very good, and there is no way, no problem to approach to coronary sinus. And then the CRT lead should go down to here, or down to somewhere. But as you can see, major cardiac vein is here, so it is a little far from the origin of coronary sinus. So I think he tried to find somewhere here, but not very good. Significant big cardiac vein in this area, but he have to come to this area. So the reason he failed to place CRT lead was the anatomy of this particular patient. The cardiac vein is a little distant from the origin of the coronary sinus orifice. I'll show other example of successful CRT lead. So in this patient, there is a functional mitral regurgitation, and this is right atrium, and the coronary sinus orifice has CRT lead applied, and then it goes to coronary sinus, and then goes to here until here. So very good placement of left ventricular lead to the left ventricular posterior wall and by CRT lead. In this case, there is the myocardium is very good, and there is no specific area to be interested to be activated, but it goes to electronic power to begin left ventricular contraction from this area. So this is not the best way, but it is a possible way to synchronize right ventricular contraction and left ventricular contraction by CRT lead. And the third case is another CRT lead with many electronic lead in this patient. So when we see this kind of this is SVC going to right atrium and ventricle. So right ventricular lead and another right ventricular lead and right atrial lead and CRT lead is all together. And in this particular case, by the CRT lead, orifice has a fibrostic tissue surrounding this CRT lead. That in this case, the fibrostic change around the CRT lead was extensive. So coronary sinus blood flow may be reduced due to this fibrotic change around the CRT lead. So the positioning is depending on the anatomy of cardiac veins, but also the response of the host, the fibrotic response of the host against the electronic lead is different by patient by patient. So in this case, the exuberant fibrotic tissue was another problem in this particular case. So I'm very much expecting very good result of CSP pacing, and I think the positioning in this yeah, it's not easy for you follow the anatomy, but because this is shrunken heart after HeartMate 3, and so this is CSP lead just below the tricuspid valve orifice, and then it penetrates in the right angle to the septum and approach to left ventricular subendocardium, which was insufficient in this case due to fibrotic change of left subclavian vein approach site and so on. Thank you.